Everybody, it's Dr. Kaveh, your Harvard and Stanford trained anesthesiologist and integrative medicine specialist, here to talk about how much anesthesia do I give my patients and how can it cause medical PTSD. You hear the sound of that beeping? That's actually my heartbeat. I did connect the EKGs to myself for a demo I did just a little bit ago teaching about the Valsalva reaction with the ultrasound that you see next to me. You should check out that video, but more importantly, that's the beeping sound that can trigger PTSD in so many patients. And yet, why does something that's so life-saving, I'm going to bring that volume down, how can something so life-saving trigger PTSD in patients? And what does the anesthesia have to do to cause that? As people are coming on, hey Alex, Stabigia, Jennifer, good to see everyone coming on. So let's talk about medical PTSD and how much anesthesia can I give to prevent it, but also not cause side effects and material harm like delirium, possibly memory problems. We don't quite know after anesthesia. So let's get to it. Number one, well, Rebecca, Robin, good to see you all. And Mary, Jay, Valentine, good to see you as well. So anesthesia, how much of it can I give depends on the individual. Because what do all anesthetics do, whether it's propofol, the white juice, whether it's ketamine, etomidate, or the anesthesia gas, like the ones that come out of the ventilator behind me? They all turn off nerves. It's how they turn off the nerves in your brain to help render unconsciousness. They can also turn off the brains throughout the rest of your body, turn off the nerves throughout the rest of your body, in your heart, in your muscles, etc., your spinal cord. That's why we have to monitor your heart so carefully, because of what it can do to your body. Hey, Donica, good to see you. And you'll actually see my heart rate's going up here because I get really excited when I talk about anesthesia and about the mind-body connection. So you can actually hear my heart rate going up as I talk about this really fascinating and educational topic, because it shows how much power we have over our bodies and minds. Alex D, you got it totally right. And Lisa, hi back from the San Francisco Bay Area. Now, the problem with giving too much anesthesia is not only that you might turn off the nerves, but you might trigger apnea, especially in patients with sleep apnea, because you turn off the parts of the brain that govern their breathing. If they already have obstructive sleep apnea, and you turn off some of the willingness to breathe or the nerve reflexes to breathe, then you might have full-on apnea, right? That's why the opiate epidemic is so much more concerning in patients with sleep apnea. Same if you're having sedation, we might need to place all those breathing tubes like I showed you before to stent open your airways. I know it looks giant, right? But this is an LMA. We put it behind your tongue to keep the airways open, especially necessary in patients with sleep apnea who might not tolerate sedation, or the endotracheal tube. It really doesn't matter which tube. These all bypass the soft tissues that prevent you from breathing. So this is one of the things that too much anesthesia might cause, that might preclude doing sedation, which is when you would ordinarily be breathing on your own without anything to support your airways being open. Another concern for too much anesthesia is turning off your brain too much and causing delirium. It's somewhere in the order of 20, 30, 40, maybe even more % of patients in the ICU, the intensive care unit, develop delirium. Why? We don't fully know why, but we believe it might be due to oversedation. Turning off the brain too much can break the mind as much as the body can break the mind while, trying to fix the body, which all too often in medicine, we forget to try to support the mind because of the mind-body connection. If you can heal your mind, you can heal your body, and vice versa. And also a sick body can cause a sick mind, and vice versa. That's why we don't want to give too much anesthesia, because of the risk of side effects. Whether memory problems, the elderly also is contributory, we're still learning. We don't know yet. But when possible, it's best to give the safe amount in the middle of the road. Gaslighting, I have a video on that, Alex. You should check it out. And medical gaslighting is in particular concerning when we're talking about anxiety, pain, depression, a lot of stuff that happens before, during, and after surgery. Now, if we don't give enough anesthesia, the problem is that the brain might still be awake enough to form memories. And if you are forming even some memories under anesthesia, when you're in an operating room like this one here, you might develop medical PTSD from hearing the beeping sounds, from feeling instruments on your body, maybe hearing drilling sounds, hearing the surgeon and anesthesiologists and nurses and whatnot talking. The problem is that the brain does not fully consolidate the memory because you have anesthesia on board. That's impairing normal memory formation. So patients might wake up from anesthesia and for days, weeks, months, years have hyperarousal, just this constant sense of fear. Maybe they'll even, in their brain, subtly, subconsciously associate it with hospital settings, but not know why they had this response, this visceral fear response, this hyperarousal to a hospital setting. Well, it's because their body kept score. Something in their brain developed a traumatic experience from the unsupported setting in the operating room. We'll get to that in a minute. That then their body remembers as some sort of PTSD, even though they consciously may not remember it. So, why did I say a supportive environment? When you're in the OR here with myself, it's a big operating room, lights, ventilator, monitors, the ultrasounds here, because I was showing on my body how to place IVs under ultrasound guidance. But the point is that when you're in this room, if you're not feeling supported, that you can't trust the providers around you, a potentially traumatic experience can turn into PTSD. Hey, we get traumatic experiences not infrequently. In a car accident, in traffic jam, whatever, someone yells at you, these don't turn into PTSD in everyone. When the traumatic experience happens without a supportive environment to help the coping mechanisms instill resilience instead of defeat and trauma, we risk that memory being encoded in the brain as a traumatic one that later turns to PTSD. In the operating room, if you have a little bit of anesthesia awareness because you didn't get enough anesthesia for your brain's needs to be amnestic, to be under hypnosis, to not be forming new memories, you can risk PTSD forming because you had the traumatic experience without the supportive environment. That's a recipe for PTSD. We call it medical PTSD if it happens here in an operating room. Hey, it's why I call my patients the night before surgery, so they can begin to instill that trust in their anesthesiologist, like they've already done, in their surgeon, etc. before, so that when they see me the day of surgery, I'm not a complete stranger to them, right? When we're asking patients to trust us with their lives, the very least we can do is to at least provide some compassion, loving kindness back. It's not a big ask, but it goes a long way for my patients, and I hope that all other doctors do this for their patients in surgery settings like this as well. Now, if maybe you're saying, well, Dr. Kaveh, just give everyone a boatload of propofol so that you guarantee they won't remember anything. Well, in addition to the risks of apnea if it's under sedation, maybe delirium if they're going to go to an ICU after, maybe heart problems because their EKG will flatline if they get too much anesthesia. The other big issue is that you can get side effects. Nausea is a big one after anesthesia. We talked about potentially memory problems, but there's also the other way is that don't give more of propofol, give more of a different medication that doesn't have the same side effects. This is what we call balanced anesthesia. Balanced anesthesia, because we don't just slam in white stuff, slam in anesthesia gas, we give multimodal. We give a combination of a little bit of benzodiazepine, a little bit of opioid, maybe a little bit of propofol or ketamine, and some anesthesia gas so that we balance out the toxicities. So I'll show you what our anesthesia cart looks like. This is my favorite part of all the OR tours, by the way, because I get to show you what anesthesiologists get to play with all day. We have local anesthetics like lidocaine. We have antibiotics here. Muscle relaxants, they all have the red warning label on them because they're paralyzing agents. Plenty of propofol here, as you can see, the blue caps. And we have emergency medications. And then we also have things like ketamine, things like opioids and midazolam that cause the brain to be scrambled enough without getting too much of the side effects from just one particular medication. balanced anesthesia. Multimodal, give it whatever name you want. There's another one in there called ketorolac, by the way, which is like a fancy IV ibuprofen. Anyways, that's just how we can help mitigate getting too much anesthesia that might overdose a patient. All right. That is how I know how much anesthesia to give my patient, to the point where they're getting enough for amnesia, minimizing the risk of PTSD, but not too much to cause the cardiovascular toxicities, etc. That balance is how it's part of the art of anesthesia. Sometimes we use a brain monitor. I don't use them often because they're very expensive and of questionable benefit for most surgeries, not all, but for most of the surgeries, at least the ones that I do most often. So it's usually a combination of heart rate variability, respiratory rate, blood pressure, all the vitals you see here. These are on myself, by the way. And that is how I know how much anesthesia to give my patients. It's always done in a loving, kind, compassionate way.